Okay, in this video I'm going to talk about the cardiac cycle and the three phases and the highlights of each of these phases. So the cardiac cycle is basically all of the events that are occurring within the heart during one heartbeat, and this includes changes in pressure and volume of blood. I recommend, if you're watching this video, to kind of follow along with your notes. Unfortunately, I'm not going off of my notes. I'm going to use this animation that I showed in class, but hopefully I get pretty close to what my notes say. So the first phase of the cardiac cycle is called the ventricular filling phase, and at this point the pressure in the heart is quite low. The AV valves are going to be open, and when they're open, blood is just flowing passively into the ventricles, and this is due to gravity. And the majority of this atrial blood is just going to flow passively into the ventricles. And when about 80% of the blood is in the ventricles, these AV valves are going to start to close. They're not going to completely close yet, but they're going to start to close because the pressure in the ventricles is increasing. Now, the atria are going to depolarize. This is after that 80% is already in the ventricles. So they start to depolarize, and that's what we can see down here on the EKG. So we can see right here, this is where we're at. We're starting to depolarize the atria, and following that wave of depolarization, we're going to have contraction. And the atria are going to contract, and they're going to push the rest of that blood into the ventricles, that 20% of blood. And when this happens, you have a small increase in atrial pressure, which is seen right here. So we have this little increase. This is right when the atria are contracting. Okay, so we have an increase in pressure in the atria at this point, and they push the rest of that blood into the ventricles. Now, all of the blood is in the ventricles at this point. The atria are going to be filling right back up, but the ventricles have their maximum volume of blood, and this is known as preload, also known as end diastolic volume. Okay, so the volume at the end of diastole. The ventricles are approaching the end of their rest period, so they're about to contract. So that's kind of where we're at now. So we've depolarized the atria, they have contracted, they've pushed the rest of this blood into the ventricles, and we can just follow it along down here. So this is, again, depolarization of the atria, the P wave, and as we kind of move along, we can see that the ventricles are filling up, and at this point, the ventricles are starting to depolarize. And when they start to depolarize, like I've said in class, following that wave of depolarization, you're going to start to have contraction. So at this point, we still have our end diastolic volume, we have the maximum volume of blood in the ventricles, and they are about to start contracting because we have our wave of depolarization, which is the QRS complex on the EKG. So right at this point, we have closure of the valves. So the pressure in the ventricles causes these the AV valves to close. And that's what gives you the first heart sound, the S1 sound. That's the lub and the lubbed up. However, there's another kind of a special little split-second event occurring here, and that's the ventricles are contracting, the AV valves are closed, but also the semilunar valves are closed. So therefore, the ventricles are contracting, but they're not pushing blood anywhere. This is known as isovolumetric contraction. So the chambers are completely closed, meaning none of the valves are open, but it is contracting. And this is just a very small split-second event. All right. But as the ventricles contract and pressure increases in these chambers, it's going to force the semilunar valves open, because the pressure is greater in the ventricles, so it's going to open the semilunar valves, which we will see right there. So at this point, the semilunar valves are open. This one is the pulmonic valve, but the same thing is happening in the aortic valve, and blood is being ejected into the vessels, so into the pulmonary trunk and into the aorta. And this is known as the ventricular ejection phase. And again, you can follow all of this on the graph, all of these pressure and volume changes. I really care more about, as long as you know what's going on and why things are happening. This graph just kind of demonstrates it in a different type of way. So that's kind of the phase two, the ejection phase. Now, Phase 3, this is known as the isovolumetric relaxation phase, which I'll talk about what that means in a second. But the ventricles are contracting, the semilunar valves are open, as we can see here. So we have complete contraction. This is following the QRS complex, following the depolarization, and then we are going to enter repolarization of the ventricles, and that's the T wave. Now, the final phase, isovolumetric relaxation phase, this is after the T wave, and this is when the ventricles start to relax. So if we kind of followed along here, the ventricles are starting to relax right about here. Now, there is still some blood within the ventricles, and this is known as the end systolic volume. Okay? The thing is, when the ventricles are starting to relax, the ventricular pressure is going to drop, and that's because the blood isn't being compressed by the ventricles. And with this, the pressure in the pulmonary trunk, which we see here, as well as the aorta, it's actually going to be greater than the pressure in the ventricles. And what happens is you will have closure of the semilunar valves. So here it's open, here it's closed, and that's where you get the second heart sound. That's the S2 sound, the dub or the dup. I mentioned in class about the dicrotic notch. This is when blood kind of hits the aortic valve and kind of bounces back. That's more of a fun fact. But it's that pressure being greater in the pulmonary trunk and the aorta that's causing the semilunar valves to close. Now at this point, you can see here that still both the valves are closed. So the ventricles are closed chambers, and this is known as isovolumetric relaxation because the ventricles are relaxed, they're in diastole, but the volume is the same because no blood is coming in and no blood is leaving. So again, if we and those are the three main phases. So if we kind of go through this again in the second heartbeat. So the P wave, this is atrial depolarization. Blood is passively flowing into the ventricles. The atria are going to contract following this wave of depolarization. They're going to push the rest of that 20% of blood into the ventricles. At this point, the ventricles have the greatest amount of blood they're going to have, the greatest volume. This is known as end diastolic volume or preload. And the ventricles are stretching here, as you can see. And then the ventricles will start to depolarize. And following that wave of depolarization, we're going to have contraction of the ventricles. As they start to contract, there it happened right there, you have closure of the AV valves. Also at this point, AV valves are closed, the semilunar valves are closed, so we call this isovolumetric contraction because the ventricles are starting to contract, but the volume of blood within those ventricles is the same. Iso means the same. However, as pressure increases in the ventricles and it becomes greater than what is present in the pulmonary trunk and the aorta, these valves open right there. So the pulmonic valve in this case opens, and the ventricles continue their contraction. They push blood, they eject blood into these vessels. Once we hit the T wave, we start to repolarize the ventricles. So at this point, the ventricles are starting to repolarize, and they're starting to relax. And then right here, we have closure of all the valves again, and this is known as isovolumetric relaxation. So the ventricles are in diastole, and all of the valves are closed, and then the cycle begins again. So blood pressure, this is just the force that is exerted on arterial walls by blood, and of course it's measured in millimeters of mercury. And the things that kind of play into blood pressure are the contraction strength of the left ventricle, how elastic the arteries are, any sort of peripheral resistance in the arteries, as well as the viscosity and the volume of blood. And we talked about how all of these can change in response to different lifestyle choices and pathology. Of course, the top number is the systolic number. That is the pressure during systole of the heart when the heart's beating. And then the bottom number is the diastolic number. This is the pressure within the artery when the heart's in diastole, when it's resting. The systolic minus diastolic pressures, this is known as the pulse pressure. Long-term blood pressure control, so blood pressure regulation. We do have a couple of short-term sort of solutions, but the big takeaway here, long-term blood pressure regulation occurs by the kidneys. We went through the whole RAS system in class again. I'm not going to ask you about it on this exam, but of course that's fair game for the final. So changes in perfusion. So we talked about ventilation perfusion matching. This is about ventilation perfusion mismatching. So again, we want the amount of oxygen we bring into the lungs, we want that to be roughly the same amount of oxygen we put into the blood. But there are cases where we can have perfusion without ventilation, meaning something is blocking the movement of air itself, but we still have the capacity to perfuse. This can occur in things like pulmonary edema or asthma. We can also have ventilation without perfusion, where we can move air without a problem, but perfusion, we can't move that oxygen into the blood or the CO2 into the lungs for some reason. And the good example of that's a pulmonary embolism. So changes in circulation. Hemorrhage, this of course is the loss of blood through a broken vessel wall. Thrombosis, this is the formation of a clot. And there are really three things that precipitate the formation of a clot. These are known as Virchow's triad, which includes excessive clotting, damage to the blood vessel wall, and also changes in blood flow, turbulence. So things like atherosclerosis are certainly things that would cause turbulence, excessive clotting, so people have some genetic clotting disorders, but I talked about how people who smoke, of course, are hypercoagulable, and vessel wall damage, again, this occurs in people with hypertension, smokers, diabetics, all of those things. Now, if the thrombus breaks free, it's called a thromboembolus. Sometimes it's just called an embolus, but an embolus is a general term for anything that is traveling in the blood and can cause an obstruction. So an embolus could be a clot, a moving clot. It could be fat. It could be amniotic fluid. It could be a number of things. Air. All of those are considered emboli. Arteriosclerosis, this is the thickening and hardening of arterial walls. And atherosclerosis, this is I like to think of this as advanced stage arteriosclerosis. So this is more significant. And this is where you have an inflammatory response occurring in the blood vessel wall. And you get the formation of these plaques within the wall of the blood vessel. All of these injuries, arteriosclerosis, atherosclerosis, they begin with injury to the endothelium, which is the lining of these blood vessels. Things like smoking is very damaging to the endothelium, hypertension, diabetes, those are all big causes of atherosclerosis. What happens with any injury in the body is it induces an inflammatory response. And then we bring immune cells, inflammatory cells, to the site. So macrophages will come in. They produce free radicals because that's what they do. That's what they do when they're trying to clean things up. However, unfortunately, when they produce these free radicals, they're not killing pathogens, but they're just damaging the blood vessel wall. And they also cause the oxidation of LDL. And LDL, low-density lipoprotein, it's probably there to deliver cholesterol to help the cells repair themselves. As more of these macrophages migrate into the intima, that's the tunica intima, which is that endothelial layer of the blood vessel, they will kind of consume this LDL that they oxidized. And when they consume those, they're called foam cells, because if you look at them under the microscope, they look foamy. They look like macrophages that are full of just like fat. And as these accumulate, you start to see these fatty streaks. You see these plaques build up within the wall of the vessel. And of course, these aren't good, especially if they form in the coronary arteries, because that could precipitate a heart attack. Or if this is in the carotid arteries, this could precipitate a stroke. So it really is a significant medical condition. The thing is, these take a long time to develop. This does not happen overnight. So by the time people are diagnosed with this has been brewing for many years. Aneurysms, these are just outpocketings of a blood vessel wall, typically in reference to an artery. Aneurysms have never killed anybody, but when they rupture, they can certainly be dangerous. They commonly form in the abdominal aorta. They commonly form where the carotid artery bifurcates into the internal and external carotid arteries, and a couple of other places. Venous stasis, this is just the slow movement of blood in the veins, in the venous system. And you'll see this, people with varicose veins, it's typically not a huge issue other than the cosmetic issue that people have with varicose veins. But that's still a form of venous stasis. That's because the valves in the veins have failed. Also, heart failure causes venous stasis, prolonged bed rest, all of those can cause venous stasis. Now, all of these things I've talked about, venous stasis, aneurysms, atherosclerosis, all promote thrombus formation. Okay, these are things that promote the formation of clots. And this is bad because, of course, if those clots get to moving, they can end up in the lungs if it's, lands in the right side of the heart, or it can end up in the brain if it's in the left side of the heart. So changes in cardiac output can be caused by quite a few things. Septal defects, so these are defects in the septa between either the atria or the ventricles or both, and what happens is you have the commingling of blood. Oxygenated, deoxygenated blood is mixing together, and that's not good for obvious reasons. You can also have defects in the heart valves. Most commonly in the aortic and the mitral valves, you can have stenosis, which is a narrowing, a hardening of these valves. Regurgitation, this is where you have blood flowing in a retrograde fashion. It's going backwards, and that's not good. Cardiac dysrhythmias, there's a ton of these cardiac dysrhythmias or arrhythmias, and these are electrical disturbances in the heart. They're dangerous when they change how the atria and the ventricles communicate with each other. And a heart block, this is an obstruction somewhere in the cardiac conduction system. Typically occurs most often in the AV node, which is an AV block. Sometimes it's noticeable, sometimes it's not. So here's just a couple of examples. This is a septal defect in the atria. This is known as a patent foraminal valve. There's one in the ventricles. This is just a couple of examples. There are other possibilities also. And then here we have stenosis of tricuspid valve. So the disease is hypertension. This is elevation of systemic arterial pressure. I believe it's 130/90 now. Used to be 140/90. There are a couple of types. There's primary hypertension, which is the vast majority of cases. Primary hypertension, essential hypertension, idiopathic hypertension all mean the same thing. You should be familiar with those three names. But again, this is by far the most common. It's a multifactorial disease, so it does not occur in response to any other disease. Risk factors, smoking, of course, high sodium intake, obesity, family history, age, all of those things that we are familiar with. Secondary hypertension, this occurs in response to another disease. You see this with kidney diseases. Sometimes, if you have like an adrenal cortex tumor or really any tumor of the adrenal gland can cause changes in epinephrine output and aldosterone output. So there's a number of things that can cause secondary hypertension, but it's quite rare. So clinical manifestations of hypertension, typically none, at least early on, but as it continues, people may see changes in vision, heart disease, because the heart is working harder to push against this greater pressure, problems with the kidneys, but these are chronic complications of hypertension that's pretty much been untreated or poorly treated. So as far as treatment, lifestyle modifications can take people a long way. I'm going to say that about pretty much any disease. But of course, all the typical players here when it comes to the drugs, so ACE inhibitors, ARB blockers, beta blockers, diuretics, all of those are used very commonly. And here's just a sign. Diagnosis, ideally should use readings, multiple readings over a 3 to 6 month period. Unfortunately, those recommendations aren't always followed. So a heart attack, this is known clinically as a myocardial infarction or an MI. This is where you have death of these cardiac myocytes due to an interruption of blood flow to the myocardium. Most often caused by atherosclerosis of the coronary arteries, which is coronary artery disease, CAD. And what happens is these cardiac myocytes, they do not have oxygen, they start to die. One by one, they undergo apoptosis, and as this continues and continues and continues, the site of infarction becomes greater and you have necrosis. The problem here is when you have death, you have the necrosis of these cells, you interrupt the conduction of the heart, the conduction system. And this is what can kill. This is when you get these life-threatening dysrhythmias. Now, if you survive, these cells will degrade, fibroblasts will come in, and they will lay down scar tissue. And this can cause problems later on in life when it comes to conduction system in the heart, so you may have problems with arrhythmias and dysrhythmias later on. Clinical manifestations, sweating, that sudden crushing chest pain, pain that is referred to the jaw or the shoulder, sometimes nausea, vomiting, sometimes just the feeling that something's not right. Complications, the most severe is sudden cardiac death, which is due to that interruption of the conduction system. Electrical instability, which can come early on or later on. Dysfunction of the left ventricle, which can lead to heart failure. So there are certainly complications if you're lucky enough to survive a heart attack. So diagnosis, EKG, history, exam, and of course troponin. You'll see increased troponin levels, which is a protein that will be released from these dead cells. Treatment, administration of aspirin, blood thinners, antithrombotics, PCI. You will use this mostly for STEMI cases where you have an ST elevation, myocardial infarction. That's basically a cath. But if that's unavailable at the moment, you would give a thrombolytic to try to break up the clot as quickly as possible. So here you can see, if the severity of the heart attack really depends on where it occurs. If it occurs way up here, high up in the coronary arteries, you're going to have a much more significant pathology. If it occurs down here in these smaller areas, you might not have such a tough road ahead. Here, all of this is dead. This is all necrotic heart tissue. Pretty significant. This is probably what killed this person. Okay, stroke or cerebrovascular accident. There are ischemic types and hemorrhagic types. The ischemic types, this is when there's some obstruction. Maybe it's a thrombus that formed within an artery supplying an area of the brain, or maybe an embolus that originated from the left side of the heart, got lodged in a blood vessel in the brain. Hemorrhagic, these are often due to cerebral aneurysms that have ruptured. Both cases are going to result in decreased blood flow to the brain. The hemorrhagic types will also increase the intracranial pressure. So risk factors, hypertension, smoking of course, number one risk factor, diabetes, increases in the number of red blood cells, which is polycythemia, that makes a person hypercoagulable, as well as AFib, and we talked about AFib. If the atria are fluttering, that blood is kind of sloshing around, and that promotes the formation of clots. If you form a clot on the right side, that can go to the lungs. If it's formed on the left side, it can go out to the body, including the brain, which can cause a stroke. TIAs, transient ischemic attacks, these are mini strokes, and I call these your get-out-of-jail-free card because they might serve as a possible warning to something bigger, like a stroke. But basically, these are short-lived neurologic symptoms, typically lasting less than an hour, has to resolve within 24 hours to be a true TIA. Clinical manifestations, you'll have the contralateral motor and sensory deficits, numbness, paresia, ataxia, problems walking, confusion, problems speaking, dysphagia, dizziness. I use the little acronym in class, the FAST, face, arm, speech, and time. That's what you would, and again, it really depends on where the stroke is occurring as far as these manifestations, but these are kind of the general ones. Okay, then we talked about heart failure, and this is just when the heart is no longer able to pump blood effectively to meet the demands of the body. Risk factors, hypertension, of course, but also ischemic heart disease. So if people have coronary artery disease where blood flow is not getting to the heart, or they have history of heart attacks, those are certainly risk factors for heart failure. Obesity, problems with the kidneys, age, some congenital heart defects can cause heart failure, valvular issues can cause heart failure. There's lots of things. It could be a side effect of medication. The list kind of goes on. Now, you can classify heart failure as acute and chronic, systolic, diastolic, but we're just going to talk about left-sided and right-sided heart failure. Again, right-sided heart failure most often is the result of left-sided heart failure, but they can occur separately. So left-sided heart failure, also known as congestive heart failure, sometimes CHF is used just to describe heart failure in general, but we'll just call it left-sided heart failure. So what happens is you have increased preload, increased end diastolic volume, and this is because the heart, for some reason, just can't quite keep up. It's starting to fail. And as you increase the end diastolic volume in the ventricle, left ventricle, it starts to stretch. And I showed you that curve, okay? So if we have this here, this little curve that I showed you, and I did this here, we want to be about right here. So if this is stretch and this is contraction strength, it doesn't matter which axis it's on. As the heart stretches, it actually contracts more strongly, but only for a bit. Okay, once you start to get over this hill, it starts to get weaker and weaker and weaker. And that's the problem with heart failure, is you get over that hill, and it's hard to get back over that hill. And in most cases, you can't. So as the ventricular wall is stretched and its function decreases, blood starts to back up. Okay, remember, the left side of the heart receives blood from the lungs. So as it's failing, blood is starting to back up into the left atrium, into the pulmonary veins, back into the lungs, and patients will have dyspnea, especially upon exertion, but not always just exertional. Orthostatic hypotension, so drops in blood pressures upon standing, decreased pulse pressure, decreased peripheral pulses, and as this gets worse and worse and worse, you have pulmonary edema. Because that blood is backing up into these pulmonary capillaries, it's pushing fluid out. It's increasing that capillary hydrostatic pressure within the lungs. So you have pulmonary edema, which of course is worse upon lying. So the right ventricle is then going to start to get involved because as this blood is backing up into the lungs from the left side, the right side, which pumps blood to the lungs, is having to work harder because it's pumping against all of this resistance in the lungs. And that's what's going to precipitate its failure in most cases. So left-sided heart failure, again, these are all of the kind of the manifestations. Some of the big ones here, though, is pulmonary edema. That's really characteristic of left-sided heart failure as it gets worse. And then right-sided heart failure. So again, this right ventricle is starting to enlarge because it has to push against this greater pressure in the lungs, and this reduces its function. You have tachycardia, decreases in cardiac output, palpitations, but also we're going to have increases in central venous pressure. All right. And this is going to increase pressure in the visceral veins like the hepatic portal vein, and this is going to cause congestion in the liver, so you can have problems with the liver at this point. You will also see jugular vein distension, because remember, the right side is receiving blood from the body, okay? So when it's receiving blood from the body, but it's failing, it's not pumping blood out as efficiently, it's starting to back up also. And on the left side, blood backed up into the lungs. On the right side, blood's going to back up into the system. So that's why you'll see distension of the jugular veins. You'll see this increased central venous pressure in regards to the hepatic portal vein. But also, as it continues to back up into the system, this increases capillary hydrostatic pressure in the system, and this is going to push fluid out, and you see this pitting edema in the lower extremities. That's kind of characteristic of right-sided heart failure. So manifestations here, clinical symptom or evaluation, diagnosis, history, clinical symptoms, an echocardiogram, chest x-rays, you'll see the enlargement, lab tests like stress tests and things like that. As far as treatment, you want to increase how efficiently the heart pumps and preventing further failure. So when I show you that curve, you basically want to stop going down that hill. That's kind of the goal of treatment. So as far as kind of quick and dirty types of ways to treat it, diuretics to remove fluid as quickly as possible. So if somebody has pulmonary edema, that has to be treated. Bed rest, digoxin, which is going to increase the contractile strength of the heart. Compression stockings for edema, trying to move that fluid back into the circulation. Vasodilators, and like I said, pulmonary edema has to be treated. Again, right-side heart failure, you have this congestion in the tissues, in the system, and that's where you see problems with the liver because of that increased central venous pressure. You'll see edema, ascites because of that pressure in those visceral veins, Very similar to what you see with cirrhosis. Although they're different, they are related. So those are kind of the big takeaways for right side failure. As always, if you have any questions, please let me know. Okay, so this lecture was about alterations in ventilation as well as elimination. So we basically talked about the respiratory system and a little bit about the urinary system. So some definitions here. Ventilation, this is just moving air into or out of the lungs. Diffusion, this is the process of basically exchanging gases, oxygen and CO2, across both the respiratory membrane and the cell membranes. Perfusion, this is the process of supplying oxygen to the tissues by forcing blood into a capillary bed. And then respiration, this is the basically making energy from oxygen. We can respire without oxygen, but most of our energy is made using the oxygen that was delivered to the tissues. So this is just showing these gas exchange structures. So these bundles here, these are the alveolar sacs. The alveoli make up these alveolar sacs. Individually, they're called an alveolus. And like a net over these alveolar sacs, you have the capillary beds, and that's how we exchange gases. So oxygen goes from these alveoli into the blood, and CO2 goes from the blood into the alveoli so we can exhale it. So we talked about the jobs of each of these structures, the anatomy here. I just kind of wanted to get the ball rolling. Don't worry too much about this as far as the final exam is concerned. So ventilation includes both inspiration and expiration, breathing in and breathing out. And this is triggered by a number of receptors in the body, including receptors in the lungs, which kind of monitor the current state of breathing and will adjust that accordingly. There are also chemoreceptors, which detect gas levels in the body, and this is based a lot on the partial pressures of these gases as well as the pH, which makes sense because we know how gases like CO2 can affect the pH of blood. Inspiration, for the most part, this is the only way our cells obtain oxygen. Our body obtains oxygen. And then expiration, this allows us to rid our body of CO2 and excess water vapor. So diffusion, with diffusion, oxygen is trying to get into the cells. That's the goal. Get oxygen into the cells so the cells can use that oxygen to make energy. And then carbon dioxide is trying to get from the cells into the blood. And the rate of diffusion of these gases depends on their pressure, their partial pressure, which is basically the pressure exerted by a specific gas in a mixture of gases. So it depends on the partial pressure. It depends on how soluble they are. We know that oxygen is not very soluble in water. CO2 is more soluble in water. And also the thickness of the membranes that these gases are traveling through, the pH of blood, as well as temperature. So here are some of these structures. This is a really good image, just kind of highlighting some of these things. So this is a cross-section of the alveoli, and there are different cells in here. So these guys here, these are macrophages. They're called alveolar dust cells, and they're going to basically consume pathogens that make their way down into the alveoli. We also have these type 1 cells right here. These are the cells that are actually going to be involved with gas exchange with the blood, which is this. So this would be a type 1 cell here. And this is the respiratory membrane. So the respiratory membrane includes these type 1 cells, these epithelial cells of the alveoli, the endothelial cells of the capillary, and then there is a small basement membrane between these cells. And that's the respiratory membrane. That's what these gases have to travel across. There's another type of cell here called a type 2 cell, and these type 2 cells produce surfactant. And I showed this on the board, but surfactant is going to decrease surface tension. Surface tension is just the attraction that water molecules have for each other. And when we decrease surface tension, it helps the alveoli to stay open. So then we talked about the transport of these gases, oxygen and CO2. Oxygen is not very soluble in water, so very little is found in plasma. But this is okay because we have hemoglobin, and hemoglobin contains 4 iron atoms. Each iron atom can hold 1 molecule of O2. So that's how we solve that problem. Instead of transporting oxygen in the plasma, we just transport it via hemoglobin. You know, when all of these iron atoms are carrying oxygen, we say that that hemoglobin molecule is fully saturated with oxygen. So the factors that affect the unloading of oxygen, so hemoglobin getting rid of oxygen, letting oxygen go, there are a couple of them. So if you have a low partial pressure of oxygen in the tissues, hemoglobin is going to unload more oxygen into the tissues. That makes sense. If you have more CO2 in the tissues, hemoglobin is going to unload more oxygen, which makes sense because if there's increased amount of CO2, that's telling you that the metabolic demand is higher in that cell. Temperature, as temperature increases, hemoglobin is going to unload more oxygen. And also, as pH drops, the hemoglobin is going to unload more oxygen. And again, that makes sense. If there's a decrease in pH, that tells the body that CO2 levels are probably rising or possibly rising. And if CO2 is up, again, increased metabolic demands, so more oxygen is unloaded. So the transport of carbon dioxide is a little more interesting. It's more soluble than oxygen, so you'll find around 10% dissolved in plasma. The rest of the CO2 is going to go into red blood cells, and 20% will bind to hemoglobin, not to iron. It binds to the amino acid regions of hemoglobin. But the vast majority of CO2 is going to enter these red blood cells and undergo a chemical reaction, and this is the carbonic anhydrase reaction. So CO2 and water, in the presence of an enzyme known as carbonic anhydrase, will form carbonic acid and bicarbonate. So basically what we're saying here is most of the CO2 will enter red blood cells and become bicarbonate, which we know is a base. As soon as that bicarbonate is made in these red blood cells, it leaves the red blood cells and goes out into the plasma. And this is how it's carried to the lungs. However, since bicarbonate is an anion, when it leaves the red blood cell, we have to move something into the red blood cell, another anion, and we do that with chloride. It's called the chloride shift. Now, once this blood gets back to the lungs, these reactions are completely reversed, and CO2 is formed, and then CO2 is going to be exhaled, of course. This is really important reactions for the carbonic acid bicarbonate buffer system. Carbonic acid is the weak acid, bicarbonate is the weak base, and this helps to buffer changes in pH in the blood. So some topics with impaired ventilation: abnormal breathing patterns. Normal breathing is known as eupnea, which is around 8 to 16 breaths per minute. And obviously changes could possibly indicate something's going on. Hypoventilation results in hypercapnia, which is too much CO2 in the blood. And then hyperventilation results in hypocapnia, too little CO2 in the blood. Which makes sense because if you're hypoventilating, you are keeping too much CO2, and therefore pH is going to drop with that increase in CO2, and vice versa for hyperventilation. Hypoxemia, this is reduced oxygen in arterial blood, which sounds similar but is different than hypoxia, which is reduced oxygen in the cells. And then cyanosis, that's that bluish color that you see due to lack of oxygen. So cough, this is a reflex, and its job is to clear the airways. Changes in sputum, or the amount of sputum, consistency of sputum, if there's blood in the sputum, which is known as hemoptysis, all of those things indicate some pulmonary pathology. Dyspnea, which is that feeling of shortness of breath, as well as orthopnea, which is that shortness of breath while lying down. That's indicative of something like pulmonary edema, which you see in left-sided heart failure. And these are just all of these things kind of summed up here. So our first disease was pneumonia, which is an infection. It can be community-acquired or nosocomial, and this is going to cause inflammation in the distal airways. So the alveoli, the respiratory bronchioles, the alveolar ducts, and even some of the interstitial tissue within the lungs itself. So it can be caused by basically any pathogen: bacteria, viruses, fungi, sometimes protozoa, and it's spread by aerosol droplets. Or if you are a natural reservoir for one of these pathogens, you can aspirate those into the lungs, and they can set up shop and cause pneumonia. So just like any other immune response, you have acute immune cells like neutrophils coming into the site, which will try to consume the bacteria. We're going to be concerned with bacterial pneumonia for this lecture. Neutrophils come in, they consume the bacteria, they die. That's where you get that exudate and that pus, along with the leaky blood vessels from the inflammatory response. And as these immune cells accumulate and fibrin is activated, you have this characteristic consolidation that you see with lobar pneumonia. Clinical manifestations: productive cough, fever, shortness of breath, chills, stabbing, pleuritic type chest pains, and then crackles when you listen with the stethoscope. Diagnosis: CBCs, H&P, X-ray of course, and then sputum samples to identify the actual cause. As far as treatment, antibiotics if it's a bacterial case, and any other supportive therapy. Macrolides are a good family of drugs like the Z-Pak, azithromycin. And here you can see some consolidation due to bacterial pneumonia. So common causative agents here. The number one causative agent in lobar pneumonia in adults is Streptococcus pneumoniae. This is the same thing when you hear pneumococcal pneumonia. It's the same thing. That's what they're referring to. Okay, left out a U. So Streptococcus pneumoniae. There are certainly other pathogens that can cause pneumonia. Viruses can cause pneumonia, fungi can cause pneumonia, other bacterial pathogens. So there are many others, but Streptococcus pneumoniae is by far the most common in adults. Then we talked about COPD, which is kind of a catch-all term for diseases that are characterized by limitation in airflow, and typically caused by tobacco smoke. And historically, it's been classified as the combination between chronic bronchitis and emphysema, but also diseases like asthma, bronchitis by itself, chronic bronchitis by itself, emphysema by itself, all can be considered COPD. I like to think of it as the combination between bronchitis and emphysema because they are rarely separate. And then asthma, I think, is kind of in its own category, but nonetheless, you might hear those classified that way. So let's talk about each of these. So again, kind of one of the characteristics of all of these diseases that I mentioned is air can come in relatively easy. The problem is when the person goes to expire, these bronchial walls kind of collapse, and these people tend to produce a lot of mucus. And what happens is when these collapse and you have this mucus plug, this air just kind of twirls around and you can't get it out. So chronic bronchitis, the definition: hypersecretion of mucus as well as a productive cough for at least 3 months per year for at least 2 consecutive years. Inhaled irritants are going to just cause this inflammation, which is bronchitis, and with any sort of irritation or inflammation, you produce mucus. Emphysema, what happens in emphysema is you basically, I showed this in class where you have kind of these airways, and you have these alveoli. The purpose of these alveoli being set up like this is to increase surface area for gas exchange. The problem is, in emphysema, these walls between the alveoli start to break down. And all of these alveoli kind of coalesce into one stiff super alveolus. So these alveolar sacs just break down, and you really limit the amount of surface area for gas exchange. And also, with emphysema, you have the breakdown of elastin, which kind of surrounds the alveoli, and that helps the alveoli to recoil. And when you lose that, again, these alveolar sacs become stiff and very inefficient. So you can see that here. This is a normal alveolar sac. These are the walls between the alveoli. They start to break down. We also lose elastin, limiting that elastic recoil of the alveoli. So asthma is a very common pulmonary disease. It's a chronic disorder. Basically what happens is there is hyperresponsiveness in the bronchi and the bronchioles, and when they're hyperresponsive, they constrict, and there's also the production of mucus, of course. Remember, anytime you irritate smooth muscle, which as you can see, there's smooth muscle wrapped around these airways, anytime they're irritated, no matter what the cause is, they're going to constrict, and that's what's happening here. And along with that irritation, you get the production of these mucus plugs, And unfortunately, in this case, this airway is cut off, and these are hyperinflated airways, and that's not good because these can rupture. So clinical manifestations: wheezing, common cause of a chronic cough, increased respiratory rate, shortness of breath. Treatment: beta agonists, which are going to increase sympathetic output, like albuterol, inhaled corticosteroids like Advair, and of course anti-inflammatories, prednisone for acute type asthma attacks. Cystic fibrosis: this is a genetic disease. It's autosomal recessive, and it's due to a mutation in the CFTR gene, which is a chloride conductance channel in the membrane. And the problem with this is when you don't conduct chloride properly, you also don't conduct sodium. And when you don't conduct sodium, you don't conduct water. So what happens is you get this abnormally thick mucus that's produced. And this affects multiple organs, but the most severe manifestations occur in the lungs. That's why we talk about it here. So you get mucus plugs that form, and this mucus is very thick. It's hard to be cleared, and it just kind of adheres to the epithelium because the cilia can't beat this this very thick mucus up and out. It's just too thick. It's too heavy. And when it sits there, it really increases the chances of infection. So a lot of cystic fibrosis patients will die of infection. Clinical manifestations: cough, purulent sputum, especially if infection is present, increased respiratory rate, wheezing, clubbing of the fingers, and then there are other manifestations, systemic manifestations, but we're going to focus on the lungs. So as far as diagnosis and treatment, H&P genetic testing, again, this is autosomal recessive, so the parents either have to be affected or they have to be carriers for this. So family history, of course, and a sweat test. So if the chloride concentration is too great, greater than 60 milliequivalents per liter, that's indicative of cystic fibrosis. So as far as treatment, you're trying to keep the airways as clear as possible. You're trying to break up that mucus. You want to treat infections. Nutrition is really, really important because they have a decreased ability to absorb nutrients because of these conductance channels, and also bronchodilators. Life expectancy is increasing, so it's around 30 to 40 years. Males live longer on average. Why that is, I'm not sure. But, around 30 years ago, people didn't even make it out of their teens. So we are making strides when it comes to cystic fibrosis. So this is just showing what's going on. So this is actually a mutation. It can be, there's a number of mutations actually that can result in cystic fibrosis, but they all involve the CFTR gene, the chloride conductance channel. And this is on chromosome 7. And as you can see here, this is the channel. Okay, so this gene encodes for this protein, which is a chloride conductance channel. The problem is, since it's defective, chloride cannot be conducted across the membrane. And when chloride is not being conducted, that not only stops sodium from being conducted, but it actually pulls sodium into the cell. And with that, you have water moving into the cell. So all of this out here, where you want water and sodium so you can loosen up that mucus, it's not there. So you get that very thick mucus. Okay, so we didn't have time to cover ARDS. And then we went into the urinary system. So the functions of the urinary system: regulation of body fluid volume. A lot of that's because of RAS, which we went over again, as well as body fluid composition. Elimination of waste, things like urea, pneumonia. Synthesis, activation, and release of hormones like EPO, which is erythropoietin, which is necessary for the production of red blood cells. Renin, we all know what renin does. It cleaves angiotensinogen. Vitamin D actually, the majority of it becomes fully activated in the kidneys. And then long-term blood pressure control is done by the kidneys. Of course, manifestations of changes in urinary function, pain, changes in urine volume or composition, bleeding, nausea, vomiting, fever in the cases of infections. So here is the general schematic of the urinary system. So, of course, there are 2 kidneys, there are 2 ureters, the urinary bladder, and then the urethra. If we kind of look inside the kidney, we have these renal pyramids, which compose what's known as the renal medulla. And then you have this outer portion, which is composed of renal columns. The outer portion is the cortex. And at the ends of these renal pyramids, you have the renal papilla, which drain into these minor calyces, which drain into major calyces, which will drain into the renal pelvis, into the ureters, so on and so forth. Okay. I'm not going to ask any of those anatomical questions unless they pertain to the disease. So urine formation, the functional unit of the kidney is the nephron. And the nephron has two parts. It has a glomerulus and a renal tubule. I'm just going to go to this picture. So there are two parts. All of this is all nephron. And basically, the glomerulus and the renal tubule make up the nephron. Now, the glomerulus is just a very high-pressure capillary bed. And it is fed by an artery, an arteriole, called the afferent arteriole. And when this arterial blood comes in, it pushes fluid out, filtrate out. Very high capillary hydrostatic pressure here. And when it pushes this fluid out, Bowman's capsule catches it. It's called filtrate. And that filtrate is just going to move through the rest of the renal tubule. The first part is the proximal convoluted tubule. The next part is the loop of Henle. And the final part is the distal convoluted tubule. And eventually multiple nephrons will drain into this structure called the collecting duct or the collecting tubule. And basically, as this filtrate is moving along the renal tubule, stuff is being passed from the blood into the renal tubule, from the renal tubule to the blood, all the way until the body has taken back what it needs and gotten rid of what it doesn't, and that will become part of the urine. So this is just showing where the sites of transport are occurring for these different substances in the renal tubule. So we kind of went over it really quickly. I mean, you don't need to worry about the elimination of urine. It's not really important for this exam. And then we talked about kidney stones. Kidney stones are calculi. The condition of having kidney stones is called nephrolithiasis, or sometimes more vaguely called urolithiasis, the condition of having urinary stones. And these are just masses of salts that have become supersaturated and they've crystallized. Most of them are going to be calcium oxalate. But there are a number of other different types. Like there are uric acid stones, there are struvite stones, cystine stones, there's a number of other types. But the most common is calcium oxalate. More common in med, and risk factors, age 24 to 49, decreased fluid intake. I think that's probably one of the biggest, just not drinking enough water. But also diet. If you have high calcium diet, that's been linked to kidney stones, and decreased level of activity. So the pathophysiology, like I said, these salts, they start to supersaturate and they precipitate. When they precipitate, they start to crystallize. And, along with all the risk factors on the last slide, having a UTI or other kidney diseases, other comorbidities like obesity and diabetes, but also genetic predisposition, all of these things can lead to the formation of kidney stones. As far as clinical manifestations, the big one is renal colic, which is that flank pain that can change very quickly as the stone moves, or it can come on very suddenly. It may radiate to areas of like the groin. Hematuria is not uncommon at all, so that could either be microscopic or it can be gross hematuria where you can actually see it. Nausea and vomiting, all of those are pretty common. As far as diagnosis and treatment, presentation, 24-hour urinalysis, and then imaging to try to, CT scans to try and see the stone. As far as treatment, pain management, increasing fluid intake, potassium citrate, which is a known inhibitor of kidney stone formation, and if they're too large, they may either be removed or broken into smaller pieces with things like lithotripsy. This is just showing some of those different stones. And then our final disease was PKD, polycystic kidney disease. And this is when you have the growth of these cysts, both kidneys, in the kidneys, on the kidneys, and as they get worse and worse and worse, you gradually lose functional kidney tissue. I want you to think of this as an inherited disease. Most of them are autosomal dominant, but there are autosomal recessive types. And again, what happens here is you have these cysts that get bigger, they become more numerous, and they just replace functional tissue. And this causes pressure on the blood vessels in the kidneys, which I'll talk about in the next slide with how it activates RAS, but also decreases perfusion to the kidney tissue. And that's bad, obviously. Now, people can have different severities of this. They generally will always get worse, but some people get worse much more quickly, where they have complete loss of function by the time they're 40. Some people go and live a relatively normal life. So it really depends on the exact type as far as the severity of PKD. So clinical manifestations, hypertension, because this stimulates RAS. We talked about that. Flank pain, UTIs and kidney stone formation are very common, and also cysts of other organs. So since this is a mutation, it's not just in the kidney, so they'll have cysts on things like the liver, cysts on the pancreas. So these cysts are not confined to the kidneys. And those cysts on other organs can impair their function just like they impair kidney function. So as far as diagnosis, based on the presence of 3 or more cysts seen by ultrasound, also a family history and genetic testing can tell you if you have this disease. And the presence of these extrarenal cysts, these cysts on other organs, that's a huge finding. As far as treatment, just living a healthy lifestyle, supportive therapy, and end-stage renal disease care, like hemodialysis if it gets to that point. Again, not everybody reaches that point, but there's really no way, no matter what the severity is, there's no way to slow down the progression, no matter how fast or slow that progression is. So here are these cysts. Again, they just completely consume these kidneys and replace that functional tissue. This is just showing how this damage affects the kidney disease, and then, of course, hemodialysis. So that's going to wrap it up for me. Again, your exam will be, I sent all of that information out, so it's 75 questions. I sent you the topics. There won't be any surprises. All of the stuff from this lecture will obviously be new, but all of the topics will be the same that we've covered before. So just go by those topics, and of course, if you have any questions, please let me know.